Accessibility to healthcare is a challenge for many people in our area, but perhaps more so among the LGBTQ community. Studies have shown that LGBTQIA patients are less likely to consult a physician, or when they do, they may not feel confident in sharing some of the details of their life that may impact their health. Adding to this disparity, queer patients may also face discrimination in healthcare, whether by individual physicians or simply the entire medical system itself.
Our guest today is Dr. Toni Ramirez. She's a family medicine physician with Project Vida. She has several years of experience in gender-affirming care. She received her undergraduate and medical school degree from Brown University and trained in family medicine at the Santa Rosa UCSF Family Medicine Residency in Northern California. She was born and raised in Socorro and moved back to El Paso in 2020 to be with family.
Her work is strongly grounded in social justice and equity, valuing the power of community empowerment. Dr. Ramirez is a queer cis female who understands her role as a medical provider with trans experience. She practices informed consent and is open to all who are seeking health care, but is especially open to the LGBTQIA community.
Dr. Ramirez, welcome to Queer on the El Paso.
Thank you.
Let's start by talking a little bit about some of the disparities in the queer community and some of the challenges they face in healthcare. And some of the challenges may be on the industry side, on the healthcare side, but it may be a personal challenge as well. Can you talk a little bit about that?
Yes. So there are, unfortunately, so many. And I think when we talk about the queer community at large, like LGBTQ, not in talking about trans, I think, that a lot of the experiences that people face, that I even face, is just, the feeling like you're not treated the same as everybody else. That, like, fear of saying, should I say my wife? Should I not? Are they going to not listen to what I'm here to say and have some type of bias? So I think if any other oppressed community or marginalized community, I think, has the same similarities. But what I can speak to most of and that I work with more closely is just trans community specifically, or the gender expansive community specifically, is simple access to care is challenging. In the medical system today, we are very much insurance-based, right? If you don't have insurance, you have limited access. I'll speak a little bit more about what my clinic does, where we mediate that, but it's often employer-based. Most people get their insurance employer-based insurance. And people that are gender expansive and trans have some of the largest unemployment rates for a lot of reasons, a lot of discriminatory reasons, a lot of reasons we can imagine, just showing up to interviews and just not being hired. So a lot of unemployment rates then translates into uninsured rates and then no access from the logistical point of perspective. But then we walk into a medical visit or clinic or hospital, mental health place. I'm sure if you think back when we walk in, right, into clinics, it's just incredibly gendered. So gendered. Everything's gendered. One of the very first questions I'll ask is gender or sex. And oftentimes there are not appropriate choices that aren't even reflective of the actual reality of healthcare. Just very binary too. Male, female. Sometimes they won't ask the difference between gender or sex. Sometimes they will not ask, even have the option for intersex people. And this is a medical industry, and we don't even have that option, which is it's exclusionary, right? So it's exclusionary on the very first entrance. And when you first walk up to a clinic, most places, and I noticed that a lot recently, we have to change in our clinic. We had to change it. People have shifted. Is there's a good morning, ma'am, good morning, sir. There's just so much gendering at the very, very beginning. And so when we talk about like challenges to access to healthcare, it's like even before we walk into the door, to access healthcare treatment, there's a lot of like challenges and inequities that then translate into like actual healthcare inequities, right? Just not getting access to care, like primary care. And so I think there's a lot that we can kind of discuss of different healthcare inequities, but I think the biggest thing is often just the access, and then once it's accessed, just the exclusion of it. Mm-hmm. And this is just because we live in such a binary system, including the healthcare system. So binary. The system is set up to be very exclusionary, but there are a lot of places that are moving beyond that and trying that, including our clinic and other clinics that I've worked at too, where we're trying to just change our systems so that it is inclusive, because we can put a rainbow up trans flag up. We can put all these things up and say we're LGBTQ friendly, but I often think like friendly is not enough.
Yeah, there's a difference, and to be truly empathetic to the patient's needs, really start to see them as human instead of gendered or any other type of label. But, and we can talk a little bit more about the transgender experience and your care for that community in a minute. But I want to talk a little bit about the queer community at large, the gay man, lesbian. In the research that we were doing to prepare for this episode, we noticed that there is still some hesitancy on our own part, on the community's part, our community's part, to seek out healthcare. Can you talk a little bit about that and your experiences at providing care and I understand, let's say that you provide care to everybody and you're not just queer. You can't just limit all your practice to any one type of person, but certainly you would be a good person to talk to about a physician that has seen a large number of gay men, lesbians, and transgender people. So can you talk a little bit about maybe some of those challenges facing the L and the G, let's say that.
Yeah, that's a good question. I also tend to always focus in on the trans folks because I feel like the T is always just left out all the time.
Yes. Which is, and we'll talk about that in a minute because that is very important.
But very important in that even now, queer folks that are not trans they hesitate, and you said the ratings. I'd be interested to hear recent studies of information what you all read, but there's a hesitancy, and I even shared myself that even sometimes I guess as a person who's incredibly privileged, I have always had a supportive family. I don't have any doubts in the way I express myself or my life, but there is those times where in certain settings I'm do I say my wife? Do I just say my partner? Do I just leave it out?
You hesitate.
Yeah, you hesitate. And I think why did I do that? Right? Because we continue to see, right? So we continue to see the discriminatory practices or the biases or the unequal or different care. So I have seen people express to me, right? This is what the experience I've had in other places is just expressing that same hesitancy are they going to treat me differently? I'm here for my blood pressure. Do you need to know my sexual practices? And is that what you're just going to ask me? Nowadays there are certain ways that when we engage with somebody, if somebody's 26 years old, we ask them different screening questions. Health-wise, they're probably generally okay. And one of the biggest risk factors of a 20-some-year-old is sexually transmitted infections. It's just this is what it is. But when your identity has been sexualized, right, or only been seen under the sexual lens, there's a defensiveness of I'm more than that, which we are. And so even if there's good intentions coming from the medical field of this is what we ask everybody that's 22 years old, there's a defensiveness or a discomfort. So I think that's one, aspect of it, of that hesitancy. And just feeling like you're going to be treated in a different lens. You're going to be asked questions differently. Just biases. We know we're all human. We know physicians are humans and medical providers. I feel like there's this fear of bias.
How important is it for let's talk about a younger patient, let's say, for example. One of the things that in some of my other projects I've looked into, and it seems that young women or women in general kind of get enrolled into the medical arena earlier than men do, and men tend to wait until the very absolute last minute to go see a doctor and to get regular health care. When you're talking particularly about a younger generation, a younger population, that how important is it for the physician to understand their sexuality?
Yeah.
Is it? Does it color the care that you give that particular patient?
It's a good question. I think we think medically specifically. So when we think of different age frames, so you're right, is that people that have a uterus, cervix, they tend to be engaged in the medical field beyond their vaccines because they need certain screenings. Yes. And so that's where they're engaged. Other than somebody that doesn't have a cervix, and they don't really go in unless they really need to for certain aspects. So I think that when we have those individuals that go in for certain that time period, the way we approach somebody is what are your risk factors? What are the things we need to prevent health wise? And in a younger population, we're often not necessarily worried about certain cancers. We're not worried about diabetes or high blood pressure necessarily, unless they have a high risk profile. But the discussion or the topic of discussion of their health at that age, somebody young, is what their exposures are. So we talk about mental health, food, nutrition, activity, relationships with other people, more of the social aspects, and if they have any risk factors, and one of the risk factors beyond like family medicine, family history, or like, on that aspect is sexual practices. And so we need to know it for the risk profile of anybody's. And so, we need to know, like, what are your sexual practices, who are you having sex with, and how you're having sex with. From the medical perspective, I think out of the curiosity perspective, it totally depends. Like, that depends, right? But, like, we might think, like, do they need to know? Like, what it is? Yeah. Yes, for exposures. And I think sometimes we don't realize that when you go to the doctor, of, like, why do they ask them a question and not them a question? Because I think we don't really do a good job in the medical field of describing, like, what is the purpose from my perspective of your visit?
Yeah. Why are you asking me this question, and how can I possibly help as a physician?
Yeah.
How that information might enlighten me as to how to provide better care for you. Mm-hmm. And so, as opposed to just filling out the information and saying, why do they need to know this?
Totally. Right. Yeah. And I think it's kind of like the healthcare industry at fault is that, like, everybody has such a different idea when they come into the clinic or the medical visit of what they need out of the visit, or what's supposed to happen, or what they expect. And that's one of the biggest challenges, and also, like, in a good way for me, is to always try to assess that with people. Is like, what is it that you expect out of this visit? What is it that you need? Because some people I just need to make sure it's cool, it's good. Like, yes, great, awesome. I mean, all I need is you to say, I'm good for this rash or whatever. Great. Others are like, I need more than just that reassurance. I have a lot more. I'm coming in because I want you to ask me all these questions. I'm not going to tell you what I need you to ask me, but I need you to ask me all these questions, and hopefully you're going to ask me something that, like, it's really going to connect to get to where I need. And that light, I think, like, sometimes we don't understand, like, why are we asking these questions? Right. And we don't ask them out of curiosity necessarily.
Izzy had a lot of experience in the 90s doing HIV testing and counseling for the mostly gay men in the area. And this was a different time. I understand that. But getting people to kind of just be open about their sexual practice, is, even though they may even be out. But I think one of the things that might be challenging, and Izzy can help speak to this too, is that what if somebody isn't out and doesn't really feel comfortable telling their parents or their family, or sometimes their wives or husbands, that they might be doing things sexually, or they might be questioning their own sexuality, and within the confines of the physician-patient relationship, they might be a little bit more willing to open up. Has that been the case? Izzy, have you had an experience with that as well?
Absolutely. I recall that there was during the pre-counseling session, there's a cadre of questions that you have to get to, and you use those questions as prompts in order to move them in that direction. Yeah. And it depends on the counselor and I guess the practitioner in your case to kind of sense what that patient is hiding. Or that client, as we used to call them, is hiding, because they do, and because they fear judgment and those kinds of things. But it is almost up to the practitioner to introduce the idea of, are you engaging in in these kinds of things, and in some cases that can put people in a defensive mode.
Yes.
Yeah.
Big time.
And I think we take it for granted that everyone understands that if you go to a physician, they're going to maintain your privacy. That is part of the whole deal.
Right. Yeah. That's so ironclad.
Right.
Yeah,
like,
absolutely.
where is that disconnect? Why don't they understand? Is it because of, you think, everything else that they're encountering in their life?
I actually think that, like, I still find that people still worry about it. They don't trust the confidentiality of it, especially if there's individuals, maybe, like, for that example, people, like, they don't want anybody else to know. They're not out yet. They don't want to have this discussion. Is that there's this fear that somehow it'll be written, in documentation, in paper, in time. And I think nowadays we know there's so many ways to access stuff
Information.
online. We have no privacy. We really don't have privacy. There's a confidentiality between me and that person.
Right.
But like I write something down in that form. Lots of people have access to it. They shouldn't access it unless they have access. But I do think there is some hesitancy,
Right.
actually, on that confidentiality. And I will say, I think like sex is still such a tab. Like people still don't want to talk about it. They like whisper about it. They're nervous about it. So our job as like the practitioners and counselors is just to normalize it, act like normal, talk about it, and just it may not happen the first time. Right, but the second time, like, okay, this person's like doesn't really care. Okay, awesome. I can talk about it, and just using language and just it is a challenge to get people to talk about sex without feeling judged, even if it's non-queer sex. Like,
Right.
they're like they don't want to talk about it.
To approach it even clinically, I was talking to Ceci and Izzy earlier about the first time I went with my husband, who turned 65, to the doctor, and I'm helping him fill out the forms, and they ask if you're homosexual, and I click yes, and he's like, oh my God, that's the first time I've ever put that on a form. I'm like, well, now you're on the list. And it was interesting to me because we were already married. I'm his husband, and I was there, and I put myself down as his spouse, as emergency contact, and even that it could still trigger that. So, is there a generational acceptance too? Do you think older patients might be less willing to share, or is there not really any kind of correlation there?
I think there probably is, but I also do think now things have maybe shifted. So yes, there's like this generational trauma, right? Or like history of actual like feeling nervous about more than bias, but like violence, right? And this direct discrimination of like housing, jobs, whatever it is. I think it still persists, in certain senses. So I think there is that fear. I think generationally is probably powerful, right? To not have ever been able to do that or fear people and then do it for the first time. And I think unfortunately the way politics have shifted now is that there are young people now, where they may not have experienced any kind of discriminatory practices that we had decades ago, but they're fearful of documentation, specific for trans folks. That list is a legitimate conversation that some people have of, do I want to do this? Do I want to put my name on things? And I think I used to be like, you're good, you're fine. It's all confidential. It's fine. Like, don't, you're okay. Don't worry about that. This would never happen. Things have happened, right? Restriction of access to like hormones and stuff for trans folks have happened. Our governor and our general attorney has reached out to get a list and want to know who changed their name, their gender markers, who's a part of PFLAG. And so luckily those in the laws have been stopped. Like they haven't been allowed to do that. But I do think now there's just yet another affront of a fear of having things written.
They have a discriminatory, like a pathway to discrimination.
And I don't want to be like, oof, like, because I find this balance, like, we don't want to like alarm people or anything, but it's just reality. A lot of the patients that come in and speak with me, there's this fear. They ask, what's that in my documentation? What does that look like? And I think I used to want to be able to be very reassuring.
Right.
But now I'm like, I understand your fear, and this is what we're going to do.
The fear is legitimate. And I think that you certainly understand why people seeking gender-affirming care would be hesitant to be very open. And there have been cases where patients have had to move, to seek out the care that they wanted. So we'll talk a little bit about the transgender thing. But before we do that, tell us a little bit about, you were born in El Paso, went to Socorro, and you've been around the United States and San Francisco, I believe. And what made you come back to El Paso to open a practice here?
Yeah, so I've always wanted to move back. So I grew up here, went to Socorro High School, and I went to the East Coast for undergrad and medical school, and then I was in California in Santa Rosa, so like north of San Francisco,
right?
For my medical training. I've always wanted to come back. I think I always wanted to go to school to be able to come back and provide here. I'm also very close to my family. I love my family. never, friends will speak about like, oh, the holidays, I can't wait to get back home, and I love it. I could stay home, be home all the time. So I love my family. It's always the intention to come back for family reasons, just to be in community. I really value community. I love being a part of a community, and I was a part of a great community in California. That's where I met my wife, and we loved the community we created, but it wasn't the same. It just wasn't the same. I wasn't
the cultural aspect.
Yeah. And it's like, it was the same type of people we were working with, the same community in terms of my patients, very similar, very, very similar, but it wasn't my community.
Right.
And it's just like, I wanted to come back here.
Yeah,
I wanted to be able to like do that here with my family and do it around my family and get to do that. And then lastly is just, acknowledging that there was a lot of affronts happening in Texas, a lot of shifts and changes where access to the care that I provide has just been incredibly limited, and there's so few people who provide these different types of care, where I felt it even more necessary in a way to come back, to be able to do that. And I felt safe doing that because this was home.
Right.
Some places, some providers may not go to other states. It's just like they're nervous too. Yeah. But this was home, and so I really felt like the need to. If I got this training, I want to be able to use it in a space that really needs it. Right.
Well, that's certainly admirable, and I think this community certainly needs advocates, particularly medical professionals that advocate for that in throughout Texas, but particularly here in El Paso. Let's talk about the transgender affirming care that you provide. As I understand it, your clinic, Project Vida, is a general practice, right? It is, you can be a primary care physician, but you do have a sort of like clinic that specializes in gender affirming care. And then you're having a grand opening at the end of the month of a new clinic still. And so we'll talk about that as well. But tell me, what, aside from what you just said, what in specializing to the needs of the transgender community, what are some of the most challenging aspects to you as a physician in treating your patients? What are some of the bigger issues that you've had to personally deal with?
Well, I think a little bit kind of clarification on some stuff too is that, yes, so like I work at Project Vida Health Center. It's not my practice.
I see.
I feel like it's not my practice. There's a community health center. So it's a federally qualified community health center. There are 3 in El Paso: Project Vida, La Fe, and Centro San Vicente.
Okay.
Which is awesome. And it kind of speaks to kind of the challenges too, is that we're federally qualified health centers, so we provide care to everyone. Anyone cannot deny access to care for inability to pay, or they have insurance or non-insurance. So that's really awesome for the community, because there's very limited places you can do that. And so it does help with the limited access for those that are uninsured. It's a sliding scale. We will work with you. We will never deny access or care for you if you can't pay something. And so as a subset of that, there are different clinical sites. And when I came on to work with Project Vida, there was a brand new clinic that was going to be opening up. And I'm like, do you want to be at that site? That would be perfect. So it's great. So now I'm at this site. We have a grand opening coming up. And so I'm the only clinician there. And so while I work for the institution, it's nice because it's kind of my clinic-ish, right? Because I'm the only provider there. So we have a little bit more control of like the culture and the culture we create in that community, because there's in that clinic, because it's a small amount. And yes, I provide general primary care to everybody and do gender affirming integrated. And I really value that because it's primary care, gender affirming care integrated into primary care. So there are a lot of places you can go get specialized care and you just go for that, get your hormones, and that's all they do. But I get to both manage your high blood pressure and your testosterone.
And make sure that there's no conflict too. Isn't that important?
All of that's important because of the whole picture. Luckily, kind of side note is that like there's almost like no contraindication, very low risk to starting hormones and anything, like super, super simple. But what's nice is that the reason I went to family medicine is just to get the whole picture of a person, right? So I get to talk to them about things. They get to come in and get their preventative health care with me and not have to worry about getting their like pap smear as a trans man somewhere else. They just get it with me. We already have that rapport and that relationship.
I see. That makes a lot of difference to the patient.
Time.
Yeah.
Yeah. And so before I practiced, it was only gender affirming, and it was so challenging to not be able to help someone with their blood pressure because they weren't going anywhere else. they were coming in to get their hormones, but they just like the kind of, we talked about the discriminatory or just hesitations to go to medical facilities. They didn't want to go get their healthcare. They didn't want to go in and be asked any questions. They weren't going to go anywhere else. And so here it provides them the opportunity to like, we can work on your blood pressure. We can figure that out while we do your testosterone, while we do your estrogen. So I do really think that it's a very unique aspect of integrating that. So people might experience it. They get their PrEP or HIV care from their primary care doctor, which is also amazing. They don't have to go to a separate physician for that aspect. Yeah, so that's the goal and the idea, is that the integration part of it. I think the challenging parts for me as a provider in providing this is just the system. Our healthcare system is, like I talked about, incredibly binary. For instance, if we're speaking about a trans man, so trans man is somebody who is assigned female at birth, has a uterus, usually, will like have a uterus or cervix, and they are on testosterone, and either identify as a trans man, transmasculine person, a man, or non-binary. But let's say I have somebody and they change their gender marker officially, and they have an M marker. In the system, we have an M marker, we have their name, they have a cervix. I need to do a pap smear for this preventative screening. I actually cannot pick a diagnosis code that has, like for pap smear, preventative. If they have some bleeding, they have some bleeding from the uterus, I can't pick uterine bleeding.
Because they're assigned male.
In the system. And so it's like that stuff like that, systems are incredibly frustrating.
And that's fundamental. I mean, one of the things that what your clinic is providing, and when I say your clinic, I mean, is to treat the patient as a whole. That the integrated medicine part is extremely important, because it would seem to me that a trans man or woman or patient, they would almost separate that part of themselves if they needed to go see a primary care physician. And so that creates a conflict into itself, as to you have one physician offering, this kind of care on one side, and they feel forced to go and hide that from another physician. And ultimately that may lead to health issues and put them at risk. And so the integration of including all of that care for a trans person is extremely important. But yet again, the system can't handle that. And so so how do we move forward from that? What do you think?
Just change the system, and there's ways to do it. And so a lot of places are trying to shift it. They're making their own medical record systems, or they're working with the medical system. So a lot of medical systems, and talk about systems, is like the EMR, the electronic records. And people may not even know this, but like every health facility has their own, and they choose it based on the cost, the deal they got. And so it's very much, it would be amazing if there was one system and we all use the same one, but it's just the market, it's capitalism. Just like find which one. And so it's all different. And so some are great, and they are changing the way they do things to be able to allow to put different diagnoses, or to allow the difference between gender and sex, or the organs that you have, and be very specific. So are people that are doing that, but for the most part, most EMRs, Metros don't do that. And so the way to move forward is to change them, is to literally just remove ourselves from the binary aspects. And I think that's the biggest challenge, is that we all live in such this binary system of male, female, male, female, male, female. And it's so limiting, and not only limiting logistically, right? I may not be able to order that pap smear on somebody, or that screening on somebody. I can, but it's a lot of manipulation that has to happen to do that. And then when you throw insurance in the mix, it gets a bit more complicated. Super complicated. That's a huge challenge. But even just removing the binary to have just some freedom in how we live and talk about our lives. And we just I think moving forward is just really removing that binary, that when I'm doing quotations, and like a man or a woman, they kind of come in, that we don't have a certain conversation with them, because it's tinted. We have these certain ideas of how we have a conversations with somebody based on their sex or gender. They're
or they're assumed.
Exactly.
Assumed
gender.
We
change the way we talk to people. And I think other things moving forward is our medical institutions need to shift in how they're teaching and engaging with folks of how to talk with someone about their body and their bodies.
I was gonna ask about that, about in training and getting physicians and healthcare practitioners to utilize the tools of different gender choices and when they speak with their patients, the things that we're all learning to ask, how do you like to be referred, those kinds of things. So that is something that I think that would be beneficial when physicians and nurse practitioners,
which all stems from just having more diversity.
Exactly.
In diversity in healthcare, in their teachers, and everything.
For sure.
If we could solve all of the world's problems right here, that would be the biggest
You
thing,
heard it
right?
here first at Queer on El Paso. But it's
More health
interesting.
inequities.
But it's interesting in that looking at the overall population, what is your patient load that is transgender?
Yeah, that's a great question. I have to think about that. But in general, it tends to be higher because that is my specialty. And there are very few providers in the community that do that. But to give you an example, I used to work at Centro San Vicente and I was only doing gender affirming care. I wasn't doing primary care. And within the span of about a year, but only 2 clinics per day, like 2 clinics per week, So not like a full schedule, right? I established about 150 people established care with me. So 2 days, so about 100 and some days of clinical time, through that first year, barely starting, getting the word out, right? So putting all those factors together of like newish services with them and not working there full time, I established care with about 150 people that were gender diverse.
Wow.
And so those people a lot of them have transferred care to see me at the clinic that I'm at now. But this week, for instance, I had 5 new people coming in to establish care. Either were already on hormones or wanted to initiate or have conversations or talk about the possibility of getting some type of hormone therapy. Some people come in and don't want hormones. They just want to talk about their expression, their gender, like social transitioning maybe. So right now, I would say I'm probably maybe at least 50%
Really?
of the population, because that's what people come to me for, which I love.
Right.
Yeah. People ask and they're like, oh, this new clinic that you're going to be at that's opening up, is it going to be like a queer center, a queer health center? Like, not officially, but by default, kind of.
We'll take it.
Because, yes, we can say that. But it's not like, they're clinics over the country, right? They're very like queer-centric and specific and stuff. So this isn't the case. But we're talking before, it's just, but representation matters. So like our front desk person is a part of the queer community. 2 of our medical assistants are. The other medical assistant's son is a queer person who's a drag queen. I'm queer. And so I think that's, by default, our clinic is a little bit more of a queer center.
And it certainly breaks down almost immediately some of those barriers that some queer people might have, whether they're, just like I said, just lesbians, gays, transgender people, might have in trying to find a physician. It is almost immediately a little bit more comforting to know that you're going to be among family.
Yes. Yes, exactly. It does make a big difference. You're able to have these conversations and just understand. Studies show that when your medical provider, and even with teachers too, medical provider reflects your experience, whether it be, most of the studies are like race and gender, when they, or socioeconomic status, kind of in a way, I guess, or experience of that, it improves not only satisfaction, but healthcare outcomes.
That makes perfect sense.
So like when a Black pregnant person has a Black physician, their healthcare outcomes are better. It's not just because they feel better about it. They actually have better healthcare outcomes. And so it's the same thing with queer and gender diverse folks. That's what I'm hoping, this place creates, is that there are better healthcare outcomes, not just the experience of feeling good, but your health is actually better because we're able to talk about it.
Right.
In a way that you may not be able to talk to somebody that doesn't really understand or have your experience.
Breaking through those barriers is already green light in terms of a path to wellness, I would assume. So one of the things that we had talked about in a previous episode is there is a population of immigrants that are seeking gender-affirming care, and they're coming through our border here in El Paso. And on the other side of it, you have people in El Paso that are crossing the border to get hormones. So can you talk a little bit about that dynamic and maybe some of the pitfalls to that type of care if they're taking it in their own hands and going across the border?
Yeah. So, yes, I hadn't really thought about that aspect, but yes, that exists. For one, we are trying really hard to work with organizations that are helping receive any immigrants coming through or migrants coming through that need that care, so we're able to get that to them. So that's one thing. We're really trying hard to be able to connect that. And if anybody listening too, like, has a direct connection or you have that experience, like, let us know, because I think we have a lot of growth to do that, to solidify that. And then, yes, you have individuals that are going to Juarez to get their hormones. And it just stems to the conversations we've had before, is that access to it is challenging because a lot of people assume they can't get health care because they don't have insurance. People can assume that medications are more costly here, or they just don't know where to go and they don't feel comfortable asking a medical provider. I've heard so many stories throughout my career of people saying, yeah, we talked to my pediatrician about it, we talked to my doctor about it, and they said X, Y, and Z, just so dismissive of the case, or people refusing to do it because they don't know how, but then didn't really help to refer somewhere else. And so there's a lot of reasons why people go over to Juarez to get it, that and I try my best when people tell me they're doing that, or a friend is doing that, or they're thinking about it, they did it in the past, they'll like apologize to me. They'll say, like, yeah, like, or they feel embarrassed, like, I'm really sorry, like, yeah, I was going over there and that's what I was doing before. I'm like, that's great, I'm glad you were able to access it, that's awesome, good. People need to do what they need to do. Our healthcare system is so restrictive that, like, people do what they need to do, and I'm glad that they had access to it. And so I think it's unfortunate that people feel like they have to go to get it there because there's access here, but I understand it. And hormones are so safe. So safe. I always tell people, because some people, even they want them, they're a little nervous. Like, is it going to be safe? What's the risk factors? I really want this, but I have questions. As a medical provider who prescribes a lot of medications for a lot of different things, there's so many medications that are very dangerous, and I get nervous. We like talk clearly that this is how you take it. This is a thing. This is the idea. We're going to follow up with you. But with hormones, some of the safest medication, safest medications to prescribe. I don't worry about the harmful effects that might happen. It's amazing. They have amazing effects and they work really, really well. We all have hormones in our body and they work perfectly fine in us. And so I'm not worried about the risk. So when people do go get medications and I don't worry about it. I think just the discussions I have with people is that not all hormones are alike. And so there are some that are better and are technically safer than others. And so just have conversations about, making sure you're getting estradiol alone and it's not combined with another hormone. And the same thing with testosterone. It's just testosterone and not combined with anything else because it's better and safer. And so I think it's fine. And then I just also let people know that it's pretty affordable here in the U.S. There's something called GoodRx. There's organizations like the BRC who help people pay for things that they need. We try our very best to limit cost. If you qualify for a sliding scale, labs are free at our clinic. That's often the most costly thing. And so it's very accessible here. But some people still don't want to do it. I've met people out and about and they're like, meh, I'll explain it to them and they're like, meh, I'll just keep doing what I'm doing.
But I know people who have insurance and still won't go to the doctors, still go to Juarez and get their medicated. And it's like
but it kind of speaks to our healthcare system that there's a lot of mistrust. In our healthcare system, they want to wait in line, they want to do this and that. It's a whole nother podcast.
That's absolutely.
The whole other episode.
There's some attitudinal inherency there. I think that particularly, to kind of dig on our own culture, but a lot of Mexican American, Mexican, Latino, Chicano, however you say it, very interesting with doctors. Mm-hmm. I had a doctor once tell me that she said, I don't understand my patients. She said, I'm a physician. I care about you. I want you to be healthy. And when I tell you to take a drug, they say no, they don't want to take it. But they'll go to their neighbor and they say to put dog shit on their face because it'll help them, and they'll do it. And so it's one of those cultures. It's a cultural issue that I think that we have faced for many generations. That still probably persists.
Yeah, I will say, like, kind of on that aspect is that I think it persists because the way our in many cultures, I've worked with different people in different cultures, is that our medical system is very westernized. Uh-huh. It's very binary. It's very colonized. It's very exclusionary. And I think that when our medical system came out of public health of prevention, and we had antibiotics and we found pharmaceuticals, like, whoa, we can cure things. That's amazing. But we've kind of gone so far into that, and it's very paternalistic. I think our medical system is incredibly paternalistic. Not all providers are like this, but it happens where it's just incredibly paternalistic. We're like, I hold all the information. I give it to you as appropriate, and you listen to me, and you will be healthy.
And you be grateful for everything.
It doesn't really work that way. The idea is that, I think medical education should be for everyone. Everybody should know, when you might need antibiotics for an earache versus not, when you might need antibiotics for a cold or not, because it's not incredibly difficult to decipher that necessarily. Right. Yes, we are trained a lot. We have a lot of experience. There's a lot of different things that, yes, are unique that you need training for, but there's a lot of education that we just kind of withhold, as in this, this is ours and this elitism. I needed to come to me for it. And I think patients see that. I think patients that are very culturally connected, they see that I don't know if you have any confidence in me. That's how I've experienced patients thinking they've experienced where providers don't believe them. Right. So they're I know my own body. And so that's, one of my philosophies literally in healthcare, the way I approach healthcare is that I believe in bodily autonomy, in empowerment of somebody's own health, of understanding their own health, and community, right? And understanding all of them. And I think a lot of people, I used to get defensive when people would be like, oh, the doctors don't know anything. My grandma would say that. My uncle still says that. Los doctores no saben nada. No saben. And I would get so defensive. And I realized I get what they mean. Mm-hmm. They're not listened to oftentimes. They're not listened to. They're dismissed. And yeah, I think when they don't trust us, they don't trust us. And that's something that really needs to be fixed.
Being a caregiver for my parents who have since passed on, but they lived until their 90s, you realize that you have to be your own self-advocate or the advocate for the person for whom that you're caring for. And a lot of times when the Latino community particularly, they do instinctually put doctors at a higher level. And so they kind of don't feel that they deserve to speak to the doctor as an equal to just come out and say it, right? Mm-hmm. And so that's another issue too. There is a lot of dynamics involved there, and it is cultural, but I also think it's probably somewhat universal. I think that there is something about the medical system in the United States that does kind of but we do put doctors on a pedestal, and I always talk to my doctors and I say, look, I'm like all your patients. I'm on WebMD, so I just know just as much as you do. And they laugh. But then I get to the point and I tell them, this is what I learned and this is what I think. And they seem immediately a little bit more amused by it, a little bit more okay, this person has perspective. There are also patients that get on WebMD and it can, there was a time, I'm a hypochondriac, so I was convinced that I had cervical cancer. Because I read the symptoms and I know that's what I have. And then I realized I don't have a cervix. But the point is that, so there's that other side of it too. But I think that one of the things that I love that you really stress is accessibility. And certainly your personality, the people working at your clinic, the people that are that your potential patients would be able to go and see, there is a very relaxed sense of accessibility to the physician and to the support staff. Mm-hmm. Tell us a little bit about your our grand opening coming up about your clinic.
Super excited for it. So the official grand opening is Saturday, July 20th. It's an all morning kind of an event. So classically, we have ribbon cuttings for different facilities or whatever. We have a ribbon cutting, little speeches, and we're done. But we wanted to integrate it into a lot of the awesome work that Project Vida's outreach team does. So we have a huge, amazing outreach team of promotoras de salud, community health workers that do a lot of engaging in the community. And they're having a backpack drive and a little food dispensary for back to school. And so we combined them. So let's just do it at the same time. So people come in and they have the opportunity to come visit the clinic and see it. I think sometimes when there's a grand opening, the community that's going to use it necessarily isn't invited, but like all the people involved in the building, logistics or politicians, everybody else is invited, but not like the patient that's actually going to come see the clinic as the grand opening.
It was technically built for them.
Yeah. And so I'm not saying this but that's how I've imagined in other places. I don't know what other clinics have done here locally, but that's usually how we see it. And so the outreach team was like, let's just do it together. And so we're really excited about that because we're hoping that people from the community are going to come out and do like the fair, and they're going to get to understand all the services we provide. And there's going to be ribbon cutting, and then they'll get to like walk through the clinic and see it. It's still a little bit bare because we're brand new, putting stuff up and figuring stuff out. But it's a nice space. The idea is to have it be a welcome, homey space and have the care that people need. So we'll have labs there on site. In about a month, we're going to have a mini pharmacy with medications that are available at very, very low cost. And at some point, we're going to have a little bit of a community room to do group visits. So we can have different types of group visits there. And then our navigation and health educators team will be there to provide assistance with any type of other social services that are needed, which is incredibly helpful. And we'll have a mental health team with a therapist and a psychiatrist, and we're hoping the therapist that's going to be coming on board has a trans experience themselves, and so it's going to be good and exciting and fun.
That's good.
Very exciting.
So that'll be July 20th.
Yes.
Saturday, July 20th from 8 to 12.
Correct. And the 8 o'clock is when everything starts, but I think the ribbon cutting and stuff is around 9 o'clock.
And the address of the clinic is
4304 Dyer Street.
4304 Dyer. And for more information about the grand opening, you can always go to our website, www.queeronda.com. Dr. Ramirez, this has been very enlightening. I think that the community is fortunate to have a caring physician. I think that the queer community should embrace this practice and we should all support each other.
Yes, I agree. Please come and welcome, because I agree. I don't do this by myself. We do this in community. And so I'm excited to meet you all and continue to work with you all.
Welcome to our community.
Our community of guests and listeners. I love working together. We're so much stronger together. We work in silos, I think, a little too much.
Yeah.
Thank you for downloading this episode of Queer on El Paso, Health and Care. Izzy, Cess, I think that was illuminating, learning a little bit from the doctor's perspective about healthcare in the LGBTQ community. But one of the things that stuck in my mind is no matter what issue we cover, politics are always underpinned in everything we talk about.
Oh yeah, they play such a huge part in everything, especially in healthcare. We need to dedicate ourselves to making sure the right people are in office.
That's absolutely right.
Absolutely. And a call out to everybody, you need to get to the polls because your freedoms and your rights and your own protections are at stake. It's never more critical than it has been now.
Izzy and Ceci and I were having a conversation about what our political stance is, and I think that the three of us are in complete agreement that our number one priority is to vote against any candidate that is affiliated with Project 2025. If you're not familiar with Project 2025, we have information on our website, queeronda.com. But most importantly, it's a threat to all of our freedoms, not just our LGBTQ community, but many other freedoms that we've come to enjoy. So this political season, we will make sure to take a few minutes in every episode to remind you all to vote and to get people to vote.
Your vote is queer activism.
Absolutely right.
We'd love to hear from you. Email us at feedback@queeronda.com or visit our website and leave a comment.